Okay, it's 4 o'clock UTC and various other times wherever you are. Welcome to everybody to the first webinar in a new series being promoted by the Partnerships for Life Global Initiative to Prevent Suicide of the International Association for Suicide Prevention. I'm going to do a short presentation. We've got some really interesting presentations following, but I wanted to give you some background on the Partnerships for Life project and a little bit about the webinar series, so that you can see what we're intending to do through this series. A couple of housekeeping. I don't have to tell you where the toilets are, which is a relief. Questions in the question and answer, please. What will happen is after the main presentations, there will be a discussion, question, answer, and discussion, and that will be moderated through my colleagues. I'll come to Mark Signor and Thomas Niederkrotenthaler, and put in questions at any point in the presentations, and then we'll try and get through as many of those as possible in the question and answer session afterwards. The other bit of housekeeping to let you know is that we're intending to record each webinar and make it available through IASP, through our web pages of the Partnerships for Life program, so people can listen to it who can't listen live. Okay, let me go into my presentation, share my screen. Okay, so Partnerships for Life, an introduction to the flagship global initiative. The rationale for Partnerships for Life, it really starts with the recognition by the organization, by the association, and also, of course, by the World Health Organization, about the importance of encouraging, supporting, motivating countries to develop, implement, and evaluate national strategies. There are a number of national suicide prevention strategies in place in the world. We think the total is something just over 40. That's probably the total of around 45 that ever have been strategies, but currently there's probably around 40. Although this is it's very good that the number is increasing over time. The majority of countries lack such formal action, and those countries can be found particularly in low and middle income groups. And of course, I should remind you that the majority of suicide deaths that occur in the world actually are in lower and middle income countries, not in high income countries. The rationale for the program, the simple rationale is a feeling that we need to increase the number of nations worldwide that are committed to a comprehensive strategic approach to suicide prevention. So what do we mean by a national suicide prevention strategy? Well, first of all, it's a systematic way of developing a comprehensive integrated approach to suicide. It provides a structural framework to support effective action, and it typically adopts a sustained, coordinated, multi-sectoral approach, which involves a range of government and non-governmental agencies that work in collaboration at a number of different global geographical levels, nationally, regionally, and locally. It's above all a complex intervention, and I mention this because this is an important feature, especially when you're trying to think through what does it mean to evaluate a complex a national strategy. And it's complex for many reasons, including that it comprises multiple interacting components or interventions, which themselves interact with a context, geographical, social, political, cultural, economic, physical, in which the strategy is implemented and in which there is change and evolution over time. And we can come, I hope we'll come back to that in future webinars. Why do we need one? Well, there's a kind of symbolic aspect to having a national program, which is a recognition that the government, really on behalf of society as a whole, has a clear recognition of suicidal behavior as a priority public health issue and is committed to preventing and reducing it. It's a way of providing leadership and guidance about evidence-informed activities and how to evaluate them. A strategy typically identifies partners who are accountable for specific tasks and roles, and above all, it encourages and facilitates collaboration and coordination. It can identify crucial gaps in legislation, service provision and data collection. It should set out the kind of resources, human and financial, that are necessary. It shapes advocacy, awareness raising and media communications, and usually would have a robust monitoring and evaluation framework. The aim and outcome of the Partnerships for Life program then. So our aim sounds very simple. It's to establish an international collaboration of experts supporting the development of such a comprehensive strategic approach to suicide prevention at national level. And the outcome we've set ourselves in the first instance is to increase the number of nations worldwide which are committed to planning, implementing, and evaluating such a strategic approach to suicide prevention. Our objectives, I've got three broad objectives. Firstly, to share experience, to share knowledge, to share learning about suicide prevention programs and strategies within the different regions of the world, and I'll come to explain about that. To promote a strategic cross-sectoral and evidence-informed approach to national suicide prevention in countries within these global regions, and then to promote and develop collaboration and coordination between countries within the regions with respect to all aspects of planning, implementation, and evaluation of national programs. The structure of Partnerships for Life is fairly straightforward. It's an initiative of one of the special interest groups of the IASP, the Development of Effective National Suicide Prevention Strategy and Practice, and really is the sort of the main program for that special interest group. We've established coordinators to lead each of the 6 WHO world regions and provide leadership for the development of the program in those regions. We've set up, established, or are developing regional networks in each of these world regions. And the work of the Partnerships for Program is kind of driven by a steering group, which comprises the network coordinators, whom I'll introduce in a minute, and the IASP Executive Director, Wendy Orchard, the IASP International Advisor, Vanda Scott, and myself as the lead. And our job is to promote coordination and cooperation between the regions, to guide the development of activities in the program, and to take decisions consistent with the broad aim of the initiative. And I should add the overall mission of the association of the IASP. So these are the world regions that we use. For those of you not familiar with the WHO world regions, which are fairly curious. I haven't got time to go into why they're curious, but you can see at a glance that there are parts of Eastern Mediterranean which are in Northwest Africa, for instance, Morocco. And in the Far East, there are parts of the world that are put into the Western Pacific region and parts which are more in the Southeast Asia. But we're sticking with the WHO organization regions. And when we talk about the regions, these are the countries in the regions of the countries as understood by the WHO. So we have in Africa, the lead is Joseph Asafo. In Americas, it's Mark Signor, who I'll be introducing to you in a minute. It's Eastern Mediterranean, it's Murad Khan and Mohsen Rizian. In Europe, it's Thomas Niedencroft-Thaler. Southwest Asia, Lakshmi Vijayakumar, and in the Western Pacific region, it's Paul Yip. So we've been fairly busy. This is the start. I'm amazed to hear from Vanda of year 4 we're in now. So we've been going 3 years. And it was interesting to kind of take stock on where we've got to in those 3 years. And these are some of the headlines. We've produced global and regional operational plans to frame our work. We've identified and created effective working relationships with key country contacts. Some, of course, are people that we know well already, but there are many countries where we have had no previous contact with anybody in relation to suicide prevention, and where there are very few or no members within IASP, which we've already started to be able to make those relationships, which is a major advance. We've been developing country situation analyses to understand more about both what's going on in relation to suicidal behavior, but as importantly, its prevention, and also to understand more about the social, political, and cultural context in which the country is developing. We've supported national teams and collaborative activity under the leadership of the key contact in each country. We've delivered several workshops in various regions which support the implementation of the programme, encourage peer learning, and are intended to facilitate mentorship between countries at different stages of strategy development. Because across the countries of the world, you've got everything from countries where there is either no activity or virtually no activity, many countries, I think at least 20, where suicide is still criminalized, to countries which are already in the second or even third or subsequent iteration of a national strategy. Finland, for instance, was the first national strategy was in the 1980s, so that's 40 years ago, nearly. Other areas of progress, we have leadership teams established in all regions. We have had online and in-person meetings and workshops with partners in all the regions. We've responded to a few requests for advice and help and support in individual countries. We've input to the development of new or refreshed suicide prevention strategies in several countries. We presented workshops, seminars, other presentations at various conferences. And the webinar program was I think the last of the major new kind of initiatives that we wanted to start within this first 5 years of the program. And as you will know, this is our first one that we're having now. So that's yes, and there's one more set of progress items which relates more to publications. So we're commissioning 2 systematic reviews which will report in the next few months. One is a systematic umbrella review of the effectiveness of interventions within national programs, which we're trying to bring together the systematic review level evidence around their effectiveness. And the second one is to assess outcomes of national suicide prevention strategies, to answer the question, what's the evidence that suicide prevention strategies actually have an effect on suicidal behavior, direct or indirect? And there's a very limited literature on this, but we think we found most of it by now, and we're going through that. We should be able, as I say, to report on that soon. There's a IASP policy position which has been endorsed by the membership on suicide prevention strategies, which can be found at on the IASP website. I give the link here. And then Mark Signor and several of us, including myself, have been involved in writing a paper for Crisis, which is published very recently, about the development, progress, and impact of national suicide prevention strategies worldwide. And the major bit of work that we put together is to update the lists of national and subnational national suicide prevention strategies. Updating the list that was provided in a publication by WHO 6 years ago now, and it's a bit out of date. So we'll try and keep that updated. But if you go to that, if you go to that link, you'll find not just the listing, but also the links to all the different strategies, the actual published versions. So that's what we've been up to in Partnerships for Life in a nutshell. You can find more about it if you go to the IASP info/partnerships for life, and you'll find information there. The webinars, this is the first one, as I've said. The aim of the webinar program is, it differs from our workshop program. The aim of this program is to support the development of evidence-informed approach to the prevention of suicidal behavior across the whole of this initiative. So that will include exchanging knowledge and encouraging targeting dissemination of both research and practice-based evidence relating to planning, implementation, and evaluation of national strategies. We want to promote learning on best practice and effective interventions in relation to implementation, and to promote innovation, methodological rigor, and appropriate design in the evaluation of suicide prevention strategies and programs. Of all those, I think the third objective is the one where there's most work to be done, but that's exciting and presents lots of really interesting opportunities. Each webinar is going to be jointly organized by the leadership teams of 2 global regions. So today it's between the Americas and Europe, European region. Each is going to be recorded and made available on the website. And here's a list of at the moment, provisional dates for 2024, but please do look out for further information that you'll get once we're clear about the program and the dates. But I think 24th of April's pretty set for the next one, so please look out for information about these. So today we're delighted to have Dr. Karen Scavaghini from the CEO of Vita Alegre Institute for Suicide Prevention and Postvention in Brazil, who's going to talk about Brazil's national suicide prevention strategy. And then Alexander Grabenhofer-Eggerth and Faith Thompson are going to talk about ImpleMENTAL, the joint action on the implementation of best practices in the area of mental health. I'm now going to hand over to Mark Seigneur, who is Associate Professor of Psychiatry, University of Toronto in Canada. Mark has been absolutely a wonder at getting action going in the Americas, and he will introduce Karen. Thank you, Mark.
Thank you so much, Steve, and for your really brilliant leadership of this incredible initiative. It's an honor to be part of this esteemed group in this inaugural webinar, and a pleasure to introduce my colleague and friend, Dr. Karen Scavaghini, who, as Steve said, is going to tell us about Brazil's national suicide prevention strategy. Karen is a psychologist with a PhD in school psychology and human development from the University of Sao Paulo, and has a master's in public health from the Karolinska Institute in Sweden. She's the CEO of Vita Alegre Institute for Suicide Prevention and Postvention, and the creator of the Mental Health Map in Brazil. She's the national IASP representative in Brazil. She's the scientific director of the Brazilian Association for Suicide Studies and Prevention and the Brazilian Association for Survivors Bereaved by Suicide. Forgive me. She's also on the Meta Self-Harm and Self-Destructive Behavior Committee. So as you can see, she's just very prolific and busy, has written books and chapters and a number of programs in this area. And I can't think of anybody better to tell us about suicide prevention in Brazil. And just also to orient the group, Brazil is the second largest country by population in the Americas after the US. So it accounts for about 20% of the billion people who are in our continent. So very important country, obviously. And I look forward to her presentation. I'll turn it over to you, Karen. Welcome.
Hi, Mark. Thank you very much for your nice introduction. And thank you, everybody. It's a very honor to be here today. So I will just let me share my screen with you. Just a second. Yeah, it's working. Let me just put the chat here that I can see if something appears. Okay. So Mark gave an introduction about Brazil, and we are now 219 million people, and as you can see here in the map, Brazil and the demographic density of Brazilian municipalities, you can see that the redder it is, the greater is the demographic density. So a little bit more about Brazil and our numbers. Here are the suicide deaths, and these numbers come from the death notification system that we have, the SINAM. In 2022, we had 14,295 people died by suicide. And just like in other countries, men kill themselves more than women, 4 times more often. And indigenous people are the population with the highest rates. The risk of suicide among young Black males between the ages 10 and 29 is 45% higher than among young white males in the same age group. Just recently, a friend, Flavia Alves, published in the Lancet Americas, I don't know if she's here, one study examining the temporal trends of notification, hospitalizations related to self-harm and suicide rates in Brazil between 2011 and 2022, and investigate the differences in social demographic characteristics, methods, and regions. It's an ecological studies. So she found that 720,480 self-harm notifications in the country in this period, and more than 104,000 self-harm hospitalizations in Brazil. Self-harm notifications and suicide have increased in the country, especially in male adults and the elderly. But the most group that it's affected is the indigenous population, with the highest self-harm notification and suicide rates, but with the lowest hospitalization rates. I indicate the article for everyone that wants to know a little bit more about our rates. Here are the rates separated by the states. The number on the left corresponds to the place in the national ranking, and the one on the right, the rates for suicide on 2023. We can see that Rondônia, that sits here, today has the highest rate, and it's the land with many indigenous people. Then after we have Rio Grande do Sul and Santa Catarina that historically have high rates. A little bit of story. In 2006, Brazil developed a national strategy for suicide prevention. And the objective of the strategy was to build a national prevention plan based on the 3 axes: surveillance and improvement of information, management and care, and development of professionals. Since 2001, when the psychiatry reform law was sanctioned in the country, a lot of the models of psychiatric hospitals have given away to community service networks, leading to humanization of the treatment and the gradual closure of psychiatric beds. And because of that, in this context, the RAPS, it's the Psychosocial Care Network, was created in 2011. The aim of this network was to prevent, treat, and promote the social inclusion of people suffering from mental illness and drug misuse. And however, it's a very nice project, and the entire structure of the HAPS care, there are a lot of difficulties in accessing the services, and sometimes the functioning of the services do not work very well. And sometimes it also can be possible that you are crossed with a stigmatizing postures expressed by the non-welcome and discredit of professionals around the suffering that culminates to suicide behavior. In 2015, the CVV, that it's Befrienders International in Brazil, with the Brazilian Association of Psychiatrists and the Federal Council of Medicine, created the Yellow September that started to disseminate campaigns and activities regarding suicide prevention during the whole month. But the efficacy and challenge of Yellow September, we can keep for another discussion, because we can be here for hours talking about it. In 2015, the Brazilian Association for Studies and Prevention of Suicide was created to unite professionals and people interested to the topic. Now we are going to have our 50th national symposium this year. It will be in Brasília, in Brazil, and everybody is more than welcome. In 2019, a suicide prevention law was created. I will talk a little bit more about this law in the next slide. Also in 2019, another law about criminalization of self-harm induction was sanctioned. In 2022, the Suicide Survivors Association was created, and it's growing a little bit slowly, but it's growing. In 2023, the Security Forces National Law regarding suicide prevention was created. For you to have an idea, from 2020, 2021, there was an increase of 55% of suicide in COPs, just measuring the ones that it's in active duty. So this law, it was very welcome. And the states received federal money to develop the action in the regions. Also in 2023, we had the law project to combat fake news and regulate the internet, especially talking about suicide prevention, but it's not implemented. The law establishes standards relating to transparency of social networks and private messaging services, especially regarding the responsibility of providers for combating disinformation, increasing transparency in the internet, and also taking care of suicide prevention. At the beginning of this year, we have the approval of the bullying and cyberbullying law, which, among other things, criminalize the practice of bullying and cyberbullying, and also change several acts committed against children and adolescents into heinous crimes such as child pornography, kidnapping, and encouraging suicide and self-harm. Years can pass from the sign of the law and its implementation, as we can see now happening in the 2019 law. This is how the law looks like. So after 11 years, the national strategy, this law was sanctioned. The law makes the national strategy possible, and the objectives of this law is to develop strategies to promote quality of life, education, health protection, and suicide prevention, and also talks about information, communication, and raising awareness in the society. Also organize comprehensive care at all levels, ensuring access for different therapeutic modalities and needs, and identify the prevalence of determinants and conditions of suicide and attempts and the protective factors, and development of intersectoral actions of public responsibility, and promote the continuing education of health professionals. Postvention also was mentioned in this law, but even though the law was being signed, it was not yet being implemented, which means that almost not went from paper to practice. And the government, of course, recognized the issue of suicide prevention need, but it's missing action and strategic partnership. We can see some partnership being established in some states, but not in all of them. Some professional training was offered, campaigns in Yellow September and just in September, and the helpline, specific helpline that they were going to create never worked. This is how the course that they offered to the professionals look like, and some strategies were adopted, but most of them about courses, and this was the course developed by the Ministry of Health with a WHO and PAHO. But not everything is lost. It's a lot of things that has been done in the country. Here we can see again the map with suicide rates, and then I researched which of them had state strategies. And to be honest, it was not an easy task to find this information about state laws and plans. They are confused, they are separate, and we are even now thinking to put those informations in the map at the websites to people find those information more easily. From all the states, we can see that 18 states have already state plans, but most of the laws have been created recently, some of them just years ago, as you can see, 2021, 2019. So the years below of the rates are the years that the law was signed. The quality of those laws can also be questioned, as some of them deal with the obligation to have yellow signs in September in schools, and not include increasing people's care or increasing suicide prevention in the school system. Only Rio Grande do Sul has the law and the strategic plan really well written. 8 states do not have, or at least I did not find it, comprehensive state plans. Some of them, they have laws for schools or focusing on just on depression, for example. In this paper, it's they research about projects of law related to suicide prevention. And they found 20 law projects related to suicide presented from 2007 to 2017 in the Chamber of Deputies, but most of them, they are related to changes in the legislative, and just 6 were related to public policy. What we can see happening today are the many law projects linked to the internet and the regulation of networks that they talk just a little bit about suicide in the laws. And then when we research for suicide-related law projects, shows that more than 1,600 were presented at the Chamber of Deputies, but a lot of them are active, and of course that not of them are really for suicide prevention. Soon I will present and reflect about some initiatives and experiences linked to suicide prevention on the internet that we develop. As we can see a lot of projects of law talking about internet, we can think what more can we do than just like take out content. But just before that, we have a lot to do. The challenges are many, and with the lack of implementation of laws, in my opinion, suicide prevention in the country is moving in its slow pace. We talk a lot about the topic, especially in September, not sometimes in a good way, but effective changes and access to care need to be really, really improved. Access to lethal means after a government that encouraged the purchase of weapons, the lack of mental health care sufficient for all the demand, and we cannot find suicide crisis care centers. We really need training on safe speech for the media, and today the CVV is the only line 24-hour help center in the country. And it's not uncommon that the waiting list for the assistant exceed hours. We need to increase research and publications, but research grants are extremely difficult to obtain in the country. And we have war records, but it's necessary to qualify these records so that public policy can take place based on the needs. And we still do not have mandatory classes on suicide prevention in psychology university, which, in my opinion, it's an absurd. There must be an integration between the powers, ministries, and health programs, so that it's effectiveness of the actions and the public power to reduce the suicide rates in the country. But more than approving laws and implementing policies, it's really necessary to strengthen the dialogue about suicide in the society. Now I will present some initiatives and experiences, especially related to the internet and social media. The things that are just passing the law will not resolve the issue. The country, in the country, as we have seen, we have laws and many projects, but in practice, it's really difficult to work with the government, and ends up to being faster to form partnership with private initiatives and private companies, or look for grants to develop the work. It's how we are doing now. Suggestions are always welcome how we can integrate those things. I will present some initiatives that we have. I can send you after other initiatives, and we have never received any single cent for government for any of those projects. This is a campaign that was the first to openly talk about suicide prevention on social network in Brazil, and it started in 2018 with the support of Instagram, and reached more than 35 million people with the 2 phases of the project. Here we can see a video being used to train volunteers in a house in the northeast part of the country. The Yellow Festival took place in September and brought together experts with influencers and Insta poets to talk about suicide prevention in a different way. CODA was a bot developed to help people offer help and ask for help from people close to them. I cannot explain very deeply each one of those projects, but if someone have interest, I can talk about it later. This was a campaign to guide how to talk to young people about suicide content online. This one was a 6-month project where suicide was not talked about directly, but somehow talked. It was more focused on health use of network. We use cards, posts, lives, podcasts, and we had very famous people in Brazil participating like DJ Alok, who has millions of followers here. This one was another one that were partnered with a magazine aimed to adolescents and young people addressing the issues of mental health, suicide prevention, self-esteem, and the importance of the dialogue. This campaign was created with the young people. Unposted Posts was our first campaign in the metaverse with the support of Meta. It was about acceptance, insecurity, judgment, anxiety, and mental health, and reached more than 45 million post views. We also developed some material on how to talk safely about suicide and mental health online, and how to provide self-care information for creators. This one was a course that we developed to equip health professionals on how to identify and deal with issues related to network, internet, technology, and their influence on well-being and promoting mental health and preventing suicide. Unfortunately, many healthcare professionals, or they hate or they love the internet, and they need to understand that it's not like this. Some of the teams are here, and self-injury and suicide prevention on the internet was one of them. And then we had more than 3,000 professionals enrolled. Wow, here was more projects, but this one with a TikTok, and we receive a TikTok award for some of the projects that we made in that social media. And one campaign that we made with them, with a HESO, reached 1.9 billion hashtags. We also developed the Innovation and Research Center that we opened last year. And of course, we have support of TikTok, but we work completely independently of TikTok in 3 areas of research. Some of the studies are now open, and the reports are already produced. One of them on well-being on the internet, mental health and suicide, and another on the relationship between screen time and teenagers. Another project is the Rede Saúde Mental that got 8 million hashtags in 1 month. This was the way to put together institutions, 7 institutions, including UNICEF and CVV, and 5 creators to qualify how the mental health is being created in the content of mental health is being created at TikTok. These are the creators, and at the end of this year, we got a huge support on ads credit, $500,000 in ad credits to promote mental health content in the platform. And we also developed the Mental Health Map, which is a platform that it's possible to find in every part of the country where there is free care in mental health available. In 2 years, we had almost 1 million access in this platform, and we really want to answer the question, where can I go to get help? So the map is there to help people to find those help. I'm almost finishing. Now we are working to the establishment of a governance in the context of suicide prevention on the internet. And it refers to the development of implementation of policies, guidelines, and practices to manage and regulate online content and interventions related to suicide prevention. So to really have the strategic use of technologies it's an interesting path for suicide prevention. And we divided in 4 axes. actions. Awareness and education, risk identification, intervention and support, data collection and analysis, and cooperation and information sharing. This is one picture that I made about the development of suicidality. I will not, of course, explain one of those issues in detail because of our time, but the idea was to create an image thinking about how the internet can influence and increase the risk in different stages of suicidality. Thinking just about removing and banning content is drying eyes. We need to do much, much more than that. And also, we can reduce the risk at different stages of suicidality, depending how can we use the social media. Of course, that I know that this is much more complex, but this is the way just to give a picture of we are trying to develop. Here are other materials that we have, and I hope that I could bring some new information. This is the team that make all of this possible, and thank you very much.
Thank you so much, Karen. You definitely brought a lot of new information, showed us so many exciting things that are happening in Brazil, but also lots of work to do, which I think is an apt metaphor for national strategies around the world. If people have questions for Karen, please put them into the Q&A. I see there's actually one question there, which is a really important question about countries that are earlier along in their journey, related to Kenya specifically. But I actually think it's such an important question. I wonder if it would be for the whole group at the end. Maybe we can defer that for a moment and just for a minute or two here, especially because we're early. We should have some time at the end, just to focus in on your presentation first. I wonder about. You talked so much about awareness and the work that you're doing with social media and Setembro Amarelo, the Yellow September that's occurring in Brazil every year. And one of the issues is that if you look at national strategies, as Steve said at the beginning, they have many components. One of them is awareness. That's often right up there in terms of the earliest components. You showed it a few slides ago. It's complicated because we want to destigmatize. We don't want people to feel stigmatized about their suicidal thoughts or behaviors. We want help seeking to be destigmatized, but we also know that certain kinds of awareness can cause harm. And so that's one of the big tricky issues with national strategies. And I'm just curious, as someone who's really been deeply involved in that, if there's a country nearby that hasn't yet done this and is thinking of doing it, what would you be recommending in terms of doing that effectively but not making mistakes?
Wow. Yeah. The things that you need to have the objective, what you want to communicate, and the target that you want to have. Because if you just start to talk and increase awareness and people do not have places to go to get help that they need, you can increase the sense of hopelessness. So you really need to have a strategy for communication to talk safely and to know what are the call to action of that awareness material, of that awareness campaign. And for that, you really need to plan what you want to get from the messages, and then to plan strategically how are you going to communicate that? What we see now in Brazil is that it's a lot of people talking more about suicide. This is good to talk more about suicide prevention, but it's not like a stamp that you have to do it in September and just that. Because when we talk with people that have suicide behaviors, they say, oh, people just care about suicide in Yellow September. So to really create an awareness campaign and the awareness to be inside a strategy, a national strategy plan, need to have objective, need to be careful, people need to take care of the messages that they want to give, and also the ones that are going to give that message. Because me as a specialist, it's hard that a teenager here's what I want to say. And booklets, who really read all the booklets? We need to have different strategies to help people to talk about it.
It's such an important point at the end there. I always worry about the booklets because they have such good information, but who does read them? There's a slightly different question in the Q&A from Lauren asking about why suicide rates are so much higher in Indigenous populations. It's worth saying, of course, that's true in many countries, including ours here in Canada. But she's wondering whether the economic factors, alienation, discrimination, all of the above. What are the major factors in Brazil?
Lauren, all of the above. And they are really discriminate. They live below the poverty line. Their lands, they are fighting with people that are looking for gold. And it's really, yeah, most of people do not see indigenous people in a good eyes, unfortunately. So they are really discriminate, and they do not have access to mental health care if they need. And the people that give that care sometimes are not specialized in indigenous cultures to know how to treat them. And we can see a lot of indigenous suicide with a very early ages, like 13 years old, 14 years old. So there is also a complex issue of cultural, the way that they understand suicide, and the relation with drugs, alcohol, do not have money and not access to mental health care. A very quick answer.
Yeah, it's probably days of answer, but that's a good quick one. I see there's a question from Duncan Nkoma from Zambia, who's writing that he lost his young sister 3 weeks ago to suicide. Our condolences, and also a survivor of 3 suicide attempts. And describing about trying to raise awareness in Zambia for 4 years, and the need to raise more awareness, and the intent to open a small movement called Youth Suicide Prevention of Zambia. The question is, how can I get IASP to mentor us, train, and guide us on a movement so that we can make an impact in our community? It's a very good question. Maybe in a second I'll turn it over to Karen in case you have any questions, but hopefully Karen's answers so far have been helpful. There is a special interest group on suicide in the media at IASP, which is actually headed by Thomas Niederkrotenthaler, who you'll hear from in a few minutes. And the important thing, I think, back to our discussion here is just there's a right way to do it in a way that could potentially have pitfalls. So it would definitely be good for all of us to have a chat to help offer some support in terms of what might be most effective. Any thoughts, Karen, about that?
Yeah. Dugan, I have a lot of material, but they are I can send to you if it helps, but still, and I'm sorry about your sister. I think we really need to talk more about it, about suicide prevention and postvention, and if we can somehow unite the needs of all the countries or some countries and how to speak safely about it. It will be really nice. You can count on me if I can help somehow.
Thank you so much for that offer. There's also a question from Ikram from Malaysia about whether there's a specific approach being used to tackle the issue of suicide prevention in Indigenous peoples specifically.
Yeah, we have the Ministry of Indigenous now in Brazil, and they are really trying to do to have some efforts to help Indigenous in the suicide prevention. But to be honest, the rates are just increasing. There are lack of professionals that can go to the communities, because sometimes it takes like 3 days by boat to get to the community, and it's really difficult, the access to those places. We really need to, actually here we need to establish an indigenous suicide prevention strategy. We do not have one that is especially for them. Not that I know, maybe the Brazilians that are here, they can have more information. We also even thought to make a booklet about it, but then we thought, who would read it? It's for the healthcare professional, it's not for the, it's for the creators, it's for whom? Who could benefit for that? Yeah, it really needs a special strategy, and they are trying to work on it, but still not in a very complete way.
So maybe we'll have time for one more question. Give it to Zrinka, asking, how is postvention organized in Brazil? And is there any active follow-up of people who attempt suicide?
Postvention started in Brazil some years ago. Even the use of the term postvention, it's quite new. But some of the strategies like self-help groups started in 2006 on that national strategy. And what we can see now in Brazil, most of the care is for self-help groups when we talk about postvention. We have the Suicide Survivors Day, and we talk a little bit more about suicide postvention in that day, but still there's a lot of prejudice, and the people still blame a lot the families. So even in the suicide prevention area, we need to have more efforts to suicide postvention. We have a documentary about suicide survivors that try to help people to understand a little bit more what happens. And we see some TV shows talking about suicide survivors, which is something quite new. About suicide attempts, they tried to develop a way that they have calls of suicide attempt, but it was just in one university in one city, like a pilot project, and we do not have this really established in the country.
Thank you so much, Karen. Actually, now suddenly there's many more questions, but maybe we'll cycle back to some of them in a few minutes. But let me pass it back. Thank you so much again for just a really enlightening presentation. And back to Steve.
Thank you. Thanks so much, Karen, for the really interesting presentation, and also to Mark for great facilitation. Now I'm delighted to introduce Thomas Niederkrottenthaler, who is also doing brilliant work in the European region in relation to the program. Thomas is Professor of Public Health at the Medical University of Vienna, and he's going to introduce presenters from Europe. Thomas.
Thank you, Stephen, and thanks, Mark. And it's really great to kick off this webinar series today with our collaboration between the Americas and Europe. And I'm now really happy to introduce two speakers based in Europe. And both of them will actually focus on a very specific international collaboration that has been ongoing in Europe. It's the ImpleMENTAL project. So the first speaker will be Alexander Grabenhofer. He is a psychologist and head of the Department of Psychosocial Health at the Austrian National Public Health Institute. And he's also the main coordinator for the National Austrian Suicide Prevention Strategy. And I should say that under his leadership, the Austrian strategy has also been selected as one of the good practice models in the European Union for suicide prevention strategies. And that's really one of the main reasons why there is now this European project called ImpleMENTAL, which is about implementing parts of the Austrian strategy in 15 different countries within Europe. The second speaker coming right after Alexander is Faith Thompson. Faith has also been very much involved in the ImpleMENTAL project, and she will really tackle this objective of our webinar series. Stephen mentioned it initially, to really promote good evaluation of strategies, because we really have not enough evidence at this point. So Faith will really focus on how to potentially do such evaluation. Thompson is a project manager and researcher in the Mental Health and Prevention team at the National Mental Health and Addiction Research Center in the Netherlands, the Trimbos Institute, and she works primarily on international mental health systems reform, providing evaluation and giving support to a number of European countries. So really thank you both for being here with us and speaking about this very important topic, this very important project, collaborative project. And I'll hand over now to Alexander for the introduction. Thanks.
Yeah, hello from my side, and many thanks for this nice introduction, Thomas. I will tell you and show you only a few slides on this project Thomas mentioned beforehand to give enough time for Faith afterwards to talk about the topic of evaluation. I will try to share my screen now. I hope it works. Yeah, okay. This is a big European project financed by the co-financed by the European Commission, and it's called JA ImpleMENTAL, which stands for Joint Action Implement, mostly on the implementation of mental health programs. And in my presentation, I will give you a very short overview of the project, and then I will tell you a little bit on the work package on suicide prevention, and show a bit of different policy frameworks and which are the steps in our project. The whole project started back in 2021, and will end this year in the end of September. So it's already a quite long ongoing project. In this project, two best practices were selected by the steering group on promotion and prevention of the European Union. Mostly it's this committee is mostly from people who work in the ministries of health in the member states of the European Union. And the first best practice model, which also represent one of these work packages in this joint action, is the mental health care delivery system reform from Belgium. And the other work package, technical work package, is the suicide prevention program from Austria called SUPRA, which stands for Suicide Prevention Austria. And this work package is led by Austria and also from our colleagues from Czechia. And if you want to see further information on this project, you're invited to go to the webpage of the Joint Action ImpleMENTAL. The work package of suicide prevention, the aim of the work package is to transfer and pilot, implement selected elements of the Austrian best practice model SUPRA. The idea is really not to try a one-by-one transfer of what we did in Austria, but more to support countries to, on the one hand, if they don't have any strategy, to for the first time develop a suicide prevention strategy, or if they have already a strategy, to support them in possibly redefining the aims and the measures in their strategy. And maybe it's important to know, actually, suicide prevention strategy is mostly based on the recommendations of the WHO, and is quite similar to many other suicide prevention strategies. And maybe it was only chosen because it was a very clear, structured, with 6 strategic goals and 17 operative goals and more than 70 measures to reach those goals. But I don't want to go into details. You can see that the map of Europe and the countries in blue here, it's now 17 countries who are part at the moment of this project. 14 of them are already really implementing countries. That means they work on their strategy and they implement actions concerning to the strategy. And 3 countries have more or less the status of observers, mainly to the reason that they have already a new strategy, or they are planning to start with a new strategy after the end of the joint action. So 9 countries already have a strategy in place at the moment, and 6 countries don't have a strategy in place right now and work on a total new strategy. And in the whole project, numerous public and private stakeholders are involved. at national level, at a regional level, but also international organizations like the IASPs are involved in this project. Yeah, finally, my last slide, the steps in the project. What we do there is all the countries do a situation and the needs analysis in their country in order not to reinvent the wheel. And actually do a SWOT analysis of suicide prevention in their country, and finally end up with national country profiles. They are already available, pointing out the situation in their country. And they also should do first the implementation of first action on suicide prevention, mostly on so-called quick wins or low-hanging fruits. This is our actions that can be quickly implemented in the country and be implemented in a very short time. And the big aim of this joint action is that all the countries should end up with a national suicide prevention strategy in September this year. This will be available on the webpage of the joint action. And if you want to know more about the Austrian project, and maybe also on an idea how to come up with a national strategy, how to define and how to formulate a national strategy, there is the Supra handbook, which is a deliverable of this joint action that can be downloaded on the webpage of the joint action. Yes, this was the short introduction, and I hand over to my colleague Faith Thompson from the Netherlands, who is responsible for the work package on evaluation in this project, and she will tell you now a bit more about ways of evaluate a national strategy. Thank you very much, and I will stop my sharing now.
Great, thanks, Alex. And that means that I can start sharing. Okay, hello everyone, greetings from the Netherlands. I'm here today to talk about the evaluation framework that's being used in the joint action to evaluate the suicide prevention in implementation that is happening via Supra. So what we're going to discuss today, first we're going to talk about the role of Trimbos as evaluators in the pilot implementation of Supra via the theory of change. So I'm going to walk you through the framework we chose and why we chose the framework of the theory of change. I'll tell you the difference between outcomes and outputs, and then show you how we've done this with the countries that are currently implementing Supra as part of the JA ImpleMENTAL. Then, to finish up, I'll discuss how indicators can be developed alongside a theory of change. So, as mentioned, at Trimbos, we're responsible for the evaluation work package, and therefore the evaluation of the implementation of Supra during the implementation period, which is from September until April. The implementation period is fairly short, and also, as you can see on the slide, the grant agreement requires that the evaluation considers both the process and also the outcome. We wanted to see if what occurred during the joint action achieved what we wanted it to achieve, or what the countries wanted it to achieve. As there are so many countries involved, there are also a lot of other factors that need to be considered when developing an evaluation framework. For example, context or funding structures, geographical location, political environment, and therefore we ended up deciding that the theory of change would be the correct framework to be applied across countries when evaluating their suicide prevention implementation. So maybe you're asking, what is the theory of change? So in general, the theory of change is a diagram or a written description that aims to show why an action will lead to a desired outcome via a chain of results, and at the same time mapping out risks and assumptions. Perhaps that sounds a little bit abstract, and I promise in a couple of slides I'll show you the model itself and it will all click into place. But generally, you use a template that shows the pathway you need to follow to reach change through this chain of events. Actions lead to your outputs, your outcomes, and ultimately your impact. So why did we choose the theory of change? Other than the fact that it can be applied across a lot of different contexts and it really takes into consideration contextual differences in implementation of strategies and interventions, it's also universally recognized and respected as a form of data collection, monitoring, and evaluation. Because of the way that the theory of change works, it increases the credibility of the results, because it shows that you've really put action into place thinking about outcomes. It's very outcome driven. Results are also shown in an engaging narrative / visualization, which I promise is on the next slide, which is appealing to stakeholders and policymakers. It's also a creative way of interacting with your implementers in the evaluation process, as it's really built on co-creation. The final point is that it can be a living document. You can update it throughout the process as long as you document the changes that have happened in your country or in your situation that have led to a different outcome or different output. So here it is. This is what a model can look like. This is the format that we've used across a number of countries, both involved in the joint action and involved in other projects at Trimbos. The model you can see here is a combination of different models we have developed during the JA with the different partners. So this doesn't actually reflect one country's implementation. It's pulled a bit from lots of different countries. For context, in the other projects that we've done with countries, the implementation period can be up to 4 years, for example. So a theory of change really can be adapted to your timeline, and this will be shown in the level of detail or the level of expectation in your outcomes. Now, what I'm going to do is walk you through the theory of change from the top to the bottom. So at the top, you can see the impact. The impact is the overall goal, or some describe it as a dream, as it sits above the ceiling of accountability. This means that there will always be unforeseen circumstances or societal changes or happenings that will affect your impact. Think about COVID or the cost of living crisis or war, etc. These things that sit above the ceiling of accountability will always be impacted by these larger societal things. And this is up for debate, but arguably a good impact would include the suicide rate, as there will always be things that affect this that we don't ultimately have control over. Although your actions may want to impact this, again, ultimately there will always be big societal things that can have an impact on the suicide rate. Another good thing to put above the ceiling of accountability, arguably, is access. Access is also controlled by a lot of societal and political things that we don't have control over. For example, the government in power, etc., will always have an impact on access. Next, we come to our outcome. So this is the next level down. Outcomes are really why we are doing the strategy or why we are doing the implementation that we are doing. They sit below the ceiling of accountability because they're in our realm of responsibility. We are able to make these things happen. They're also the effect you want ultimately to achieve, and therefore often outcomes involve something increasing or perhaps decreasing or improving. An outcome is a change in state from an original point to where we want to be, a desired situation. On the slide, you can see two outcomes that we've devised based on the different outcomes written in the JA partners' theories of change. We have responsible reporting on death by suicide has increased, or knowledge and engagement has increased on the restriction of means of suicide. As you can see, there's a start point and an end point where something has increased. Now, if we go below our outcome, we reach our outputs. In order to achieve your outcome, your outputs need to be met. The next level down in the events chain is therefore the how. Outputs are generally described as tangible products that can be produced. As the name suggests, they are outputs of actions and are the products of what you deem necessary to complete in order to reach your outcome. So, for example, we have here, journalists are aware of updated guidelines. Their awareness is the product. The Papageno Award is established. The award itself is the product. Therefore, if these things are met, we would hope that in our chain of results, responsible reporting on death by suicide has increased. Below our outputs, we have activities. These describe the day-to-day actions you take to work towards creating your outputs and ultimately contribute towards your outcome. The model layers upwards, therefore. In theory, if your outputs are met, then your outcomes can be realized because you conducted your activities. So to reiterate that, the output are the how, and the outcomes are the why, making the activities the because. If the outputs are successfully produced, then the outcome can be achieved because you completed your activities. Another very important element of the theory of change are the risks and assumptions. Assumptions, as the name suggests, are conditions we assume to occur during our implementation. If an assumption is not able to occur, then it becomes a risk to implementation. So, for example, if we assume that we have funding in place and the funding is changed or taken away or adapted in some way, it therefore becomes a risk to our implementation or a risk to our strategy. Therefore, it needs to be in the model as if this thing changes, it's going to affect how we expect the rest of the model to act. So if we go back to the joint action process, so what we've done is we've developed models for each of the countries that are implementing Supra across, for each of the countries that are implementing Supra, and developed a model that reflects their implementation that we will use to evaluate their suicide prevention actions during this time period. They're all different in terms of content, but are all based off Supra and the clusters and activities of Supra. In general, each pillar of Supra is related to an outcome, and they're below it outputs and activities. So again, to go back into the process of how we reached these models with the countries, initially we had a workshop that was guided by the team here at Trimbos, and the workshop was split into two. At the beginning, we did basically what we've just discussed, go through the model, talk about the different elements, and then in the second half of the workshop, we asked countries to pick one of the pillars from Supra or one of the activity clusters to then really go into and try and develop part of the model. So we would ask them, who is involved in this, or who do you want to change, whose like activities do you want to change, what outcome do you want? And then ultimately this outcome would then build, we'd say to them, okay, well, how are you going to do that? And they would tell us, okay, we're going to do X, Y, and Z. And therefore that is the chain of results. It goes downwards from the outcome. Once we've developed the models, the next step, and we checked with countries, etc., is that we're going to develop indicators. So I can move on to my next slide where we discuss indicators. So what you can see on the screen here, it's hot off the press because we haven't shared it with the countries yet, as we're developing a video to teach them how to develop the indicators alongside their theory of change, is a logic framework. So a logic framework is basically just an Excel that contains indicators as well as means of assessment, who collects data, baselines, targets, etc. And the way that it will work is that for each output that the countries have provided us, let's say journalists are trained, we then will ask them to provide us with an indicator. So an indicator for journalists are trained perhaps would be number of journalists that attend the specific training. That's the indicator. We'll then ask them to provide us with a target and a baseline. So how many people have already received the training? How many people you hope to receive the training? And then we'll ask them about the means of assessment, who collects the data, when the data will be collected, etc., etc. And ultimately, what we want to see here is that if the indicator is met, that has been expressed, that's in relation to the output, does that then mean that the outcome is able to be realized? The outcome itself will also need an indicator, which will focus on the change in state from the beginning of the implementation period to the end of the implementation period. Also, what you can see on the slide here, the second screenshot, is how we're hoping to support the countries in developing the indicators themselves using the language from the theory of change. So what we noticed is that in each output, there is usually a verb that describes what is happening to that given output. So what we've done is we've operationalized all of the verbs and then given an example of the indicator that could be used, and then an example pulled from the Supra handbook also. So this is my last slide now, and this is just a little bit about lessons learned through going through the process of developing these theories of change that are relevant to the suicide prevention strategies and suicide prevention implementation during the joint action. So the first lesson learned is that it's really important that you're able to break down the best practice or the strategy into clusters. So Supra is broken down into pillars. And I heard from our first speaker, Karen, that the strategy there is also able to be broken down into four sections. So this is the way to think about it, would be to go via your 4 sections or your pillars, etc., and think about what outcome you really want from that pillar. I would say that it's never too early to have a theory of change session with implementers, as this allows actions to be guided by outcomes. I really think that the beauty of the theory of change is that it allows you to think about why you're doing something and then build in later how you plan to do it. Co-creation and ownership are also super important. The way that these theories of change were developed were with the implementers themselves. I would highly recommend that if you're able to get as many stakeholders around the table as possible to really build the strategy, that's where the real beauty in it is. And it's important that the strategy is built in the voice of the people who will have to collect the data for it. It's important to consider the timeline and therefore feasibility. As mentioned, we've created theories of change that last 4 years, but if something lasts 6 months, then we really need to think about the feasibility of what indicators are developed and what outcomes and outputs can be realized during that time period. And the last point, the process of building the theory of change provides time and space for implementers to consider their intentions. You can't always expect people to have the answers in one single session. Thinking about outcomes is really heavy. So sometimes it takes time to then think about how, with the capacity, resources, etc., that you have available to you, how you're really going to reach those outcomes. And that's the end of my presentation. I can stop sharing now. And thank you for listening.
Thank you so much, Faith and Alexander, for these really inspiring presentations. And we will learn so much from that evaluation for our field. So thanks for that, and really looking forward to hearing about what you find in this really quite big collaboration. There are a few questions in the chat. I'm now starting with one which is really directly related to what you have presented, Faith. So Nikki is asking, I'm currently working on my own theory of change for an implementation project I'm part of, and I'm struggling to determine how detailed to make it and how to decide where to draw the arrows, because in real life, nearly everything is connected. How to keep it small enough that it's workable? Difficult question, but you have probably thought about it quite a lot.
Yeah, and on lots of different levels as well. I completely have come up against that problem, 15 times for the joint action, and then all of the other times outside of the joint action also. Ultimately, you need to think about whether it's going to be useful to have that amount of detail for the people that are using it. So if you're sharing it with the people in the intervention, etc., I would encourage you to build it with them and see what they think should go into it. But also my advice would be to make it as high level as possible, because it is just a model. And ultimately the detail will come from the logic framework, if you plan to have a logic framework, and build out indicators in that part. I think of an example that we've got of the 4-year program. That's a whole mental health reform. And the theory of change is for 4 years. We have 2 outcomes and 4 outputs. And then really, as mentioned, the detail is within the logic framework and the indicators. So each of those outputs have, let's say, 3 indicators. And then, of course, as you know, below this, there's the activities which require monitoring. So activities either happen or they don't happen. Therefore, it's really important to also measure at that level. Did this activity happen? Did it not happen, etc. But to me, that shouldn't be in the model itself. The model itself focuses on what is produced, what's the outcome, what's the output, etc.
Thanks, Faith. And it's already 8 minutes before 6:30 in the European time. So I think we should open up the floor for all of the remaining questions, because we have quite a few more questions, and I think they are all related to, they are not directed specifically to any of the presentations. So it's really to us all. Thank you. So we have one question. So there's the question from, oh, now it jumped away.
Sorry, Thomas, maybe I can I just answered it for about Kenya. I mean, the question about from Kenya was really what happens when you have no resources and suicide is stigmatized and you get a 2-year prison sentence if you attempt suicide. And it just sounds like a very difficult situation in Kenya. And what I had just written was, it sounds like one of the first things is really to work on stigma, working on decriminalizing. Maybe I was suggesting contacting Joseph Osafo, who has successfully been able to do that in Ghana, and engaging with the key stakeholders around how to think about suicide, because if we can't get the government and the media and society to sort of think about it in a different way, it's going to be difficult for you to be resourced. But I don't know if others in the group have thoughts.
I mean, what is interesting, and it's probably similar in your region, Mark, in the Americas, but in Europe, it turns out from the workshops that we had that most countries, as the very first step, or one of the very first structured steps they did in their countries, was to have a crisis telephone line. That's obviously something that seems to be among the best feasible options for a start. There's a question from Irina here. So Irina is asking, what can be done to further facilitate eliminating stigma in a meaningful way? Very important question. And she also adds, Europe seems to be on a promising path. And then she elaborates a bit about what she has seen in Germany. And she mentions that it's positive that there are documentaries, podcasts, etc., from people with lived experience. But she also notes that there are some negatives, like these stories are ultimately happy end stories, as it appears like even people living with SME always end up being able to live a normal life. So that's obviously something really important. I'd like to give it to the group. Any ideas on that? And maybe I can start with a few ideas, because really the work on the Papageno effect and the work on responsible media reporting is directly related to that question. And I think hearing different stories about how to manage suicidal thoughts and feelings and how to address loss to suicide, that can give us really a diverse insight into what suicide means to different people, not condoning suicide or portraying life as something as if it was a jolly life people live if they struggle. So that's really not the intention behind the Papageno effect, and that's not consistent with some of the stories. One of the main problems really has been, and Mark and I have presented on that several times, it's really that some parts of stories might trigger additional suicides. Like if the focus is very much on a suicide method, even within a story of hope and recovery, we don't know what the actual impact is. So I think this your question is also a call for further research in order to see how different elements in a story of hope and recovery, what their impact actually really is. But it seems very obvious from what we know by now that it's really important to have a diversity of different stories. Obviously, not only stories of people whose suicidal feelings stopped, but also people who continue to have suicidal thoughts and feelings and who have to cope with it basically every day.
I see, Thomas, there's two more questions. Oh, sorry, go ahead, Karen, please.
Oh, no, you can go on.
See, there's a question for Faith about the impact of physician-assisted suicide on overall suicide rates and whether it reduces quote-unquote non-assisted suicide.
I can't answer that, I'm afraid. The model is more of a theory, and it's meant to be filled in with what you think for your situation. So I can't really speak on a specific case. Perhaps somebody else can, but I can't.
If it's helpful, I mean, I can add to Canada's assisted suicide laws have recently expanded quite a lot. It's complex, but at least here you actually see, it depends on whether you consider euthanasia or assisted suicide as part of suicide or not, and that's a big debate. If you separate them, often there's a reduction in non-assisted suicides, presumably because people are using assisted suicide or euthanasia as a substitute. But when you legalize it, if you add the two together, it's always substantially higher than the original suicide rate.
There is one comment from Coffee who says the improvement of mental health care in underdeveloped countries is necessary for the prevention of suicide. Can anyone comment on this? What's the role of healthcare in the whole suicide prevention strategies? I think that's the main point in that question here.
One of these where you shouldn't all go at once. Maybe I'll jump in on this one too. I think, historically people have only focused on healthcare, and I think we definitely need good healthcare. That's a crucial aspect of suicide prevention. People who are in difficulty need access to crisis lines. They need access to different healthcare supports. But part of the issue about national strategies is also now to think beyond that, to think of the societal antecedents of suicide, and to think broadly and cross and intersectorally. But certainly healthcare is a pillar.
Yeah,
yes.
And sometimes it can be through healthcare that it's easiest to find a way in. I was musing about this question of when you've got nothing, and in fact, when maybe the behavior is criminalized, where do you start? And wherever it is you can find a foothold, I would answer, it doesn't matter that it's not anything major, or it might not be what we put in, say, the top 3 of strategies to reduce suicide, but it's where you can get something in place which recognizes suicide as a priority, as an issue. And that's often, isn't it, through the healthcare system, and particularly in psychiatry because of the relationship between mental health and suicide. But therein also lies a possible danger, which is that what we know is that in some countries, suicide prevention becomes nothing other than psychiatry, which I think we now all understand is not the best way to go, if I can put it that way.
Right. There's one comment from Irina, and she says it's about reporting the truth in not the half truth. And what she says, it's important to be responsible about media reporting on suicide. However, statistics on suicides are rightfully reported. And she says there were many reports of no increases of suicide during the pandemic, and mentions it's accurate, but it was never mentioned that while the fatal suicides did not increase, the attempted suicides increased. And she says that seems cynical. Well, I can make a start with this. We know that the situations are very different across countries when it comes to media reporting, but at least in my place here in Austria, there was a lot of reporting, fast reporting actually, about increases in suicides during the pandemic. And it was so important for us to have this evaluation, this international collaboration, to really see there was no increase during the acute phase of the pandemic in suicides. And there was also a lot of reporting, also quite recently, about suicide attempts, actually a concerning amount of reporting about suicide attempts among younger people, and sometimes portraying this like a generation lost, which is really very, very, very concerning also what it means in terms of impact on young people. So for this part where I'm based of the world, I cannot confirm that we didn't have that kind of reporting. Don't know what the situation was in other places.
Yeah. I see that the time is 32 minutes past, or whatever hour you're all in, and I think we're beginning to lose a few people. I can see the numbers dropping a little bit. So maybe we should bring this to an end. We could obviously go on longer. Can I thank you all immensely? Can I thank the facilitators, Mark and Thomas, the presenters, Faith, Karen, and Alex. And also, not mentioned yet, can I thank Jackie Etchers from IASP, from the Central Administrative Office, for organizing a completely trouble-free and smooth operation of this. Thank you, Jackie. Doesn't always happen that way, and given that it's the first, I hope this sets the precedent for all the others in the series. And to Simon Williams, also from the CAO at IASP, for providing the support leading up to the event. Yeah, I think that's all I wanted to say, to thank you all very much. And I hope that many of you will join us for the next meeting, which I hope will be on the 24th of April. Thanks very much, and goodbye.
Thank you.
Thank you.
Thank you very much. Bye-bye.
Thank you.
Bye.
Bye.